Welcome everyone to today's webinar, Considering Virtual Observation for Your Healthcare Organization. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Donna Gudmestad serves as Caregility's Clinical Program Manager. In this role, Donna helps assist with clinical training, implementation, and adoption services for Caregility customers. In addition, she provides clinical consultancy services to healthcare customers regarding the development or expansion of telehealth programs. In her 30-plus years of nursing, most previously with Mercy Virtual, Donna has held various positions, having served as a bedside clinician, clinical supervisor, and assistant director of nursing, gaining a wide array of knowledge in the healthcare industry. At this time, I am pleased to turn the floor over to Donna to begin today's presentation.
Hello, welcome everybody. I am excited to speak with you today. Today's discussion, we will focus on how virtual observation systems work, behavior management, patient selection, how to assess patient risk, some legal considerations, additional use cases for the technology, and what to look for in a virtual observation solution, and then last but not least, some return on investment implications. So let's get started. Virtual observation can be performed in a variety of patient care settings. It's been most commonly used in acute care settings, but virtual observation can also be deployed in post-acute care settings as well. It can be deployed in a single hospital or facility and across an entire enterprise as well. Hardware considerations, they consist of a cart or a wall-mounted audio-video units placed in the patient room, and they transmit one or two-way video and two-way audio to a central monitoring station. And then that station is oftentimes located in either like a telemetry hub or a tele-ICU or command center, and can also be a standalone department in their own area as well. When a patient is being monitored and they begin doing an action in which they're being monitored for, perhaps getting out of bed or pulling at their IV lines, those kinds of things, the observer will redirect the patient until they come into compliance. This redirection comes in the form of instructing the patient to stop whatever the behavior they're doing, and then they can use distraction techniques to stop the patient's behavior, such as, asking them about their grandchildren or their pets or, whatever little bit of information they might know about the patient. If the patient doesn't comply with stopping their behavior, the observer then alerts the bedside staff to the room. Alerting the bedside staff is typically done by phone or a loud alert that's played in the patient's room until someone arrives. There are some various types of continuous observation for behavioral management. Most commonly is fall prevention, obviously. There's a high use case for that. Also with confused and agitated patients, poor short-term memory, and some elopement behaviors. There's also, continuous observation can be performed for other things as well around behavior, such as, family members or friends or visitors who present a threat of abuse or illegal drugs, medication, diversion of medications, those kinds of things, and doing lots of virtual observation over the years, we've seen, all kinds of behaviors, not just from patients, but from visitors as well. Risk to others is also, can also be an issue. Sometimes there are prisoners or violent patients or visitors that can place staff at risk. And again, there's also risk to self. So suicidal or self-harm can also be a use case for virtual observation as well. When we talk about risk to self, we'll get into a little bit more around that with some legal considerations when it comes to that use case. Obviously, fall prevention, as I said, is the largest use case for virtual observation today. We know that falls with injury can be very expensive, with the average cost of a fall to be about $14,000, which doesn't include possible litigation and other associated costs. With the use of virtual observation, your organization, can leverage your resources, staff more appropriately and efficiently. Staff can assist with bedside care instead of sitting in a room one-on-one with a single patient. That's a huge resource, grab to sit somebody one-on-one with a single patient for sitting purposes. You can also reduce your costs by allowing one virtual observation to observe several patients. The Caregility product, we can observe up to 12 patients. All virtual observation systems are a little bit different. Some are 1 to 10, some are more than 12. The numbers vary. In my experience, about 1 to 12 or so seems to be appropriate, depending on how those assignments are divvied up between observers if you're using more than one observer. Some patients are very active, and some not so much. So that ratio seems to be fairly appropriate in my experience. Virtual observation provides the ability to support staff across a broader population of patients who are at risk as well, and can decrease alarm fatigue by decreasing false alarms from bed and chair alarms and those kinds of things. When a person who is visually observing a patient, there really isn't so much false alarm occurring, because when that observer alerts the bedside staff, they are alerting because there's something active going on. Bed and chair alarms are great, and they should be used in combination, and all those other fall prevention strategies should be used even while you have a virtual observer observing from afar. It's just that bed and chair alarms sometimes, just the shifting of weight can, in the bed or in the chair, can, set those alarms off and unnecessarily, and it be a false alarm. Through the years, I've heard several concerns regarding the use of virtual observation and its risks with regard to fall prevention in particular. Since a virtual observer, they can't physically stop the patient from getting out of bed, it was, and it still sometimes is, assumed that virtual observation isn't a substitute for a physical sitter. The research noted here states otherwise, and in my own experience managing a large enterprise-wide virtual observation program for several years, I am also in agreement with the study's conclusion, but there is one caveat, and that is that patient selection is key. And I can't state this probably enough. Not all patients are good candidates for virtual observation. They need to be redirectable, so they need to be able to be redirected. If they stop being redirectable, then those patients may need to be considered for a physical sitter. They need to have low impulsivity those fast-moving, impulsive patients, sometimes those younger neuro patients, they're typically not great candidates for virtual observation because they're very impulsive and they're very fast-moving. And, you know, as I said, you know, a virtual person obviously can't physically stop anyone. And then they also need to be able to hear and comprehend verbal directions. So folks that are very hard of hearing, have significant hearing impairment, or are deaf, or there are language barriers, those kinds of things also are not good candidates for virtual observation as well. There are a few ways organizations assess patient risk when selecting patients for virtual observation. There's nurse-driven assessment, so that is the process begins when the bedside nurse submits a virtual observation request for a patient. That nurse or a charge nurse conducts a subjective evaluation of the patient to determine their appropriateness for a virtual observation. And if they're deemed appropriate, they are put on virtual observation, and if not, perhaps they will get a physical sitter. There's also site-driven tools that can be utilized, so a facility can use, or they can develop their own scoring tools to assess whether a patient's a good candidate. The assessment could measure the number of times a patient has to be redirected during a set time period, for example, or be used to determine a patient's fall risk score. And then there's virtual first, meaning that you might set the program to, so that virtual observation is the first line strategy or trial before a patient can be moved to having a physical sitter. So, rather than a patient just getting a physical sitter, if they appear to be a good candidate for virtual observation, that's trialed first. If they sort of fail that trial, then they are moved to a physical sitter. The legal considerations, a few recommendations around legality things. If you plan to use a continuous observation as a first-line sitter, meaning they're the only person with eyes on the patient, for those patients that are at risk to or from themselves or others, you should probably consult with your organization's behavioral health specialties, your regulatory leadership, and your legal departments. There are some state regulatory bodies. They vary from state to state. For example, some states require that a sitter be within arm's reach of the patient. In this case, a virtual sitter can serve as a second set of eyes to support a physical sitter in the room. Some states don't have that kind of regulation, and so it's just wise to check those things prior to implementing your virtual observation program. There may also be some legal considerations when you're using observation with minors. So if you have a pediatric population, there's probably some considerations around that with parental right consent and those kinds of things. So if you plan to use continuous observation for that population, you might also consult your organization's legal department. As we said, fall prevention is typically what most people think about when they're talking about virtual observation. However, there are several other use cases for the technology as well. Typically, those monitoring for falls and behaviors are unlicensed personnel. However, licensed personnel can be used for physiological observation in certain situations. Situations such as, status post-rapid response, overflow area monitoring, COVID monitoring, NICU, the monitoring of sepsis and other high-risk patients. You know, you could have licensed personnel monitoring virtually and visually from a distance for some of those use cases. Some of those things you could probably use unlicensed personnel with some, you know, escalation parameters and protocols in place, depending on, you know, what you're trying to achieve. Virtual observation can also be performed for management of telestroke, where a stroke coordinator is maybe centralized and performs continuous observation of stroke patients to help manage timelines. Same goes for sepsis patients and those bundle requirements to make sure, you know, those bundles and things are meeting the timelines that are so important. Virtual observation could also be performed from a centralized transfer center perspective to virtually assess patients waiting for transfer prior to their departure to perhaps another facility. Sometimes those patients are triaged for transfer to maybe to a larger facility by the transfer center, but they may be having to wait quite some time before they're actually transferred. Sometimes those patients deteriorate and they do not appear in the same state they were when they were initially assessed for triage from that time to the time of their departure and their arrival at the other facility. So virtual observation can be used to perform pre-transfer assessment to ensure that when they're transferred to the other facility, that they are at the appropriate level of care that they need when they are received at the other hospital. So these are just a few of the other types of use cases that the technology can be used for. So when you're thinking about, you know, virtual observation, yes, it's a great technology for falls, and we've done that for a long time, but these are some other things to start thinking about that technology can be used for as well. So when you start to look at virtual observation solutions, there are a few things to consider. You know, in looking at those solutions, you know, you may want to think about some of these things like one-way versus two-way audio and video capabilities. At minimum, it's important to have one-way video and two-way audio so the patient can be redirected appropriately and those kinds of things. Two-way video is not always necessary, although it is sort of a nice to have. I don't think any patient and or family member would like to be have a face on the screen staring at them all day, so I don't think it's necessary in the wholeness of the program, but if you need to escalate to a two-way video conversation where they can see you and you can see them, then obviously that is a nice to have, but not a necessity in all circumstances. Pan, tilt, zoom capability is important depending on your use case as well. Not having pan, tilt, zoom can limit what use cases you can use the technology for in some cases. So for instance, with physiological monitoring, if you're planning to do anything like that, the observer may need to zoom in on the blood pressure device or an IV bag or, you know, some other type of an assessment. And if you choose a solution that doesn't have pan, tilt, zoom, and you'd like to, you know, do those things, you know, now or in the future, that can be a limitation if you choose a solution that doesn't have that capability. Obviously, if you think you'll never need that capability, then, you know, that's not a necessity. Probably alerting and the notification system is probably one of the most important as well. It's vitally important to be able to get assistance to the room in a timely manner. My preference personally is that sole alerting communication is not done by phone only. Through the years, you know, nurses getting and techs getting calls to their phone nonstop. There's no way to know that one phone call is necessarily as urgent as maybe another phone call. And so having some sort of a way to, alert those folks at the bedside that they need to get to that room like urgently is of the utmost importance. I just don't think that phone communication is necessarily the best way because it's not really prioritized for virtual observation. Night vision capability is another one that can be very important. So, the observer obviously needs to be able to visualize the patient when the room is dark. And so, does the solution you're looking at have a night vision capability? That can be very important. Obviously, observation is probably used more at night than in the day. Not to say that it can't be used equally. But there are those patients that have sundowners and more confusion at night than in the day, and oftentimes the use is a little higher at night than it is in the daytime. Language translation capability. Some products have one-way language translation where the observer can use a CAN directive to the patient, like, you can choose the language, Arabic or Spanish or Japanese or whatever, and you can click on a canned response to deliver that directive to the patient in whatever language that they speak and understand, which is a nice capability. It does not, however, translate what the patient might say back to the observer. So if the patient tried to say, I have to go to the bathroom or I have pain or anything like that, the observer would not get that return translation back from the patient. So some people find this language translation capability very useful, and some do not. So, and they'd rather use a physical sitter, maybe someone who is bilingual for those patients who are not English speaking. So that is just something to keep in mind as you're looking what your preference is when you're looking at solutions. Reporting and analytics is important, obviously, for quality improvement and incident response and all of those things. You'll want to look at things like how many hours per week or month are you utilizing sitter virtual observation resources. How long are those assessments lasting? Those kinds of things, and you'll want to be able to look at that in your ROI as well. So those things are always very important to make sure that there is a good reporting and analytics package there. Hardware considerations: cart versus wall-mounted technology. Typically speaking, carts are less expensive, but can be more challenging to manage, like where to store them, keeping them charged, plugged in, those kinds of things. Wall-mounted technology obviously presents other challenges. Moving patients that you need to sit far to a room that has the technology, unless you wire every room, that can be a challenge on the opposite side. And then scalability. So is the solution scalable? Are there additional costs to scale the solution? Are there additional server requirements for expansion to other facilities? These are all good things to know up front when you're trying to make a decision around your observation solution. And then some other things, really not really talking about what to look for in a virtual observation solution, but some things to think about when you're setting up perhaps your hub where your observers will be sitting. Some things to think about are things like ergonomics. If your observers are going to be working 8 and 12-hour shifts sitting, you want to make sure that ergonomics are important. And workstations, 2 screens minimum works pretty well for an observer. Workflows: adding and discharging a patient from virtual observation. Full staff versus hard staff. There are pros and cons to both of those. handoff between observers and the bedside, what does that look like? Shift coverage, assignment rotations. Are your observers going to work a full 8 or a 12-hour shift as an observer versus are they going to rotate to another role every 4 or 6 hours so they're not sitting in front of a screen performing observation for a full shift. So those are some other things to consider. Bedside clinical education for those folks at the bedside should probably be more around cart placement if carts are used, roles and responsibility between the bedside staff and the observers, and then like observer continuing education, some things to consider for those folks are, some basic medical overview of lines, tubes, and drains, fall prevention education, camera presence, communication strategies, dementia and memory education, de-escalation techniques, those kinds of things. So you'll see here, there are a few figures here on the right side of the screen regarding annual savings with regard to labor costs. So these are, if you're beginning to write your virtual observation business case and, you would like a 30-minute session to determine your potential savings, we are more than happy to assist you. You can request a session with us, and in that request, provide us a couple of pieces of information, your average hourly rate for your physical sitters today, and your average number of sitter hours, either by day, month, or year, and we'd be happy to set something up and have this conversation with you and help you to build your business case as well. You can see from this slide there is quite a bit of potential savings when you're looking at virtual observation versus physical sitters in the room. And I think that wraps things up for our presentation today. So thank you, everyone.
And thank you so much, Donna, for such a great presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we have time for. Looks like we already have a lot of great questions rolling in. The first question is, for fall management, are you deploying video only, or do you also use wearable devices?
So we deploy, so we've deployed just video only and not wearable devices. I know there are some wearables out in the marketplace. I have personally not utilized those in my practice previously. We've used simply, an AV solution and have had, good outcomes with that.
Got it. Thank you for clarifying, Donna. Another audience member is asking, have you had experience using virtual observation in the surgical setting?
I do not. However, that could be a very exciting use case, actually. Yes.
Yeah, perhaps something to consider in the future.
Yeah. I mean, sort of your creativity, can be taken in many directions. And so, choosing a solution that meets your needs and your creative mind are important things to think about and how it might best benefit you and what you'd like to do with the technology.
Absolutely. The next question is from an audience member who's asking, from a business environment point of view, what do you think are the main barriers to rolling out virtual observation?
I think probably the first, from a business environment point of view, certainly I would imagine, probably cost upfront for the technology, purchasing the equipment and those kinds of things. There are some creative solutions out there around, billing and those kinds of things to make those purchases less painful. But I think from a business environment point of view, that's probably the one that people may have the most hesitation around, is the upfront cost of implementing the program.
That makes sense. Thanks for breaking down some of those barriers.
Mm-hmm.
This audience member is asking, if you don't recommend using phones for altering or notification, do you have other recommendations to help prioritize communication?
I think that's challenging. So I can speak for the technology that I have used. We used, and Caregility uses this as well, sort of a loud alerting system from within the patient room, so that people that are on those floors can hear that alerting sound from their environment, as opposed to calling on a phone or a pager or anything like that. People at the bedside, they get plenty and plenty of phone calls, and so it's very hard to distinguish, that a virtual observation call, which is a high priority call, being different from all those other calls that they're getting. So if you can put that notification system within their environment, and whatever that might look like, I think is a better solution. And they know that when they hear that audible alarm, and that alarm can be set to be whatever, can be manipulated to be whatever you want it to sound like. They know that when they hear that specific alerting going off, that they got somebody that needs to get there quickly.
Got it. Thanks for clarifying that, Donna. Before we go on to the next question, I'd just like to remind the audience, if you do have any other questions that you would like Donna to answer, feel free to submit those in the Q&A box you see on your screen, and we are happy to touch on them. But it looks like we have gotten a few questions surrounding patient privacy, patient consent. The first one is, how is patient privacy protected with virtual observation?
Yeah. So depending on your solution, that can vary. So some solutions have a screen, so when a nurse comes in and they want to, they need some patient privacy, maybe they need to put a catheter in, or, get a patient cleaned up, those kinds of things, bathe them, all of those things. They'll ask the observer to, put the privacy indicator on. So they'll, and so the observer can no longer see in the room, or perhaps they can just see shadow in the room, those kinds of things. It blurs the screen for the observer, so the patient has privacy. At Caregility, what we do is we don't use that kind of technology. We turn our camera towards the door, so that, in our experience, what can happen sometimes is the nurse will complete what they're doing with the patient, and they'll leave the room and forget to tell the observer to continue their observation. So when we turn our camera to the door, we can see when the nurse leaves, and if they haven't redirected us to turn the camera back on and continue observation, we know that they've left the room because we've seen them, because we're pointed towards the door, and then we can resume our observation. So different technology utilizes, different methods. So Some blur the screen, some is just a patient privacy screen, so nothing is seen, and we, we leave the visual on, but we turn it towards the door away from the patient.
Perfect. Thank you for clarifying that for the audience. One quick follow-up. Is patient consent required for virtual observation as well?
Typically, consent is not on a per patient basis. Typically, consent is written into your consent for treatment. That's advisable if you're going to, with telemedicine in general, and virtual observation as well fits into that category. It's written into the general consent for treatment is probably the easiest way to accomplish that.
Perfect. Thanks again, Donna. Another audience member is asking, is there an option to virtually observe from home, and if not now, maybe in the future?
Yeah, certainly. I think that is definitely a possible scenario. Depending on, the solution that you choose, if they have that capability, certainly that is, that can be managed, yes.
Perfect. And do you recommend a dedicated runner to physically respond to virtual attendant escalation? And if so, is this factored into ROI?
It is not factored into the ROI, a runner per se. That is an interesting concept. We've not implemented in that way, particularly if a facility is fairly large. We need someone there, as immediately as they can get to that patient's bedside. So if they're coming from the other side of the hospital, that might be a challenge. So I think that could be possible depending on, how you set that up and the size of your facility and those other kinds of things. But we have not implemented in that manner.
Great. Thanks for sharing your thoughts there. This next audience member writes, with sensors that have cloud-based connectivity for alarms and alerts, such as with remote patient monitoring, BedXit can easily send text alerts as well as local audible alerts. Have you used any video platforms that have options to add sensors?
To add sensors? I'm sorry, was that the last thing you said, to add sensors?
Yes. Any video platforms that have options to add sensors?
I have not seen that. The Caregility platform allows a text message to be sent in addition to the in-room alerting. So there is that capability in our platform. I am unsure about the other platforms, but otherwise I have not used sensors in this scenario.
Perfect. We have another audience member here who is asking, can I retrieve a recording of the observation session if there is an incident that occurred that needs to be reviewed?
So some solutions may record, and that is a question you'll want to ask if you have interest in that. I have the program that I used to manage that large program, we did no recording. Caregility does not record. Our solution does not record anything. It just opens a whole legal can of worms around recordings and those kinds of things. So, we've opted, and I've opted in the past, that, there's actually no recording. We have no capability of recording. Other solutions may have that capability, but we do not for those legal considerations.
Perfect. Thanks for clarifying that.
Yes.
This next question is, do the virtual observers perform any kind of documentation in the EMR?
I think so if your physical sitters are documenting in your EMR, then your virtual sitters should really be no different, right? It's just the manner in which the sitting, if you will, is done. So I would say that those should mirror each other. That being said, we did, in my role when I managed that an observation unit, a virtual observation unit, we did create some rows in our EMR for our virtual observations specifically around, when it was initiated, when it was discontinued, when we had to have an escalation to alert the bedside staff to the room, those kinds of things, and of course any incidents that may occur. Those kinds of things we did. Initially, we didn't do any documentation at all when we first started out because it was just, it was started out of a need from the bedside. We were in a tele-ICU setting, and a nurse would call and say, "Can you just keep the camera on and, watch my patient in room 1 while I go do X, Y, and Z?" And so that's sort of how it started for us, and that was back in probably 2008. And so back in those days, we did no documentation, and then I guess at some point there was an RCA, and you get called into the RCA, and you're going through that procedure, that root cause of an event, and we couldn't say, looking back, because those things happen, those RCAs occur sometimes several weeks or even months after the event. We couldn't say whether we were observing or not because we didn't do any documentation. So I would recommend that there be documentation, absolutely. What that looks like should at minimum be the same as your physical sitters, and you may want to add some additional, start, stop kinds of things. If that's not in your reporting and analytics package. If it is, then that's great. You wouldn't need to have that documentation, but yeah.
Great. I think that's helpful background and advice for our audience to know. Looks like we have time for one more question, which is, how many patients can be monitored by one observation tech?
So that will depend on who you talk to. There's not really a standard. There's not really a standard around that. Some solutions will tell you 10, some will tell you 25. We say around 12 is probably as many as you would want an observer to handle. And of course, it depends on, the assignment, how many of those patients are active. You certainly don't want them all to be active at the same time. That could get tricky. So, I can't myself imagine monitoring, 20 or 30 patients at once. I think that's probably a little high, in my opinion. So we say around 12 is our max. So, and that seems to be a good working number and doesn't create increased incidence.
Wonderful. Well, Donna, before we go ahead and end today's presentation, I just want to turn the floor back over to you one more time to see if there are any final thoughts you'd like to share with our audience.
I've enjoyed talking with all of you, and hope you've taken something away from this conversation. If you have any questions, or if you would like to sit down with us to talk about your potential savings and your business case, we'd be happy to do that. I believe the information was on the last slide there to reach out to us. We'd certainly love to talk with you about what you're hoping to do at your organization.
Great. Well, Donna, thank you again so much for such an insightful presentation, and thank you to Caregility for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.